Hello, everybody. It's Frances. I'm here to discuss urinary disorders with you. This probably should also be called renal and urinary disorders because we do go through both types. And you probably already know the renal system, also called nephrology, is the kidneys where it makes acid-base balances, makes urine, regulates water levels. There's electrolyte balances done there, hormone functions there, especially in regards to pain, blood pressures, etc. And then the urinary system is the two ureters that come off the kidneys, the bladder, and then the urethra. So you got two different systems, but we're going to talk about all of it under urinary disorders. And that's why I'm saying maybe it should be renal and urinary disorders because we don't cover everything, but we definitely cover for both areas. So let's go to our first slide. And there is a video a couple slides in. It can help understand this whole mess that you're looking at right now because it reminds you where functions happen and why those functions are happening. But you can see there's a lot of different parts of the body that actually have something to do with these systems. You have your liver, of course, the kidneys, even your lungs are actually participating in a lot of this. The adrenal cortex, which sits on top of the kidneys, and then the kidney itself, the little red kidney bean looking thing. So you just want to remember that there's a lot of different things participating in the electrolyte, chemical balancing, water balancing, a lot of information coming in from other areas. Assessment of the urinary system. You're, as a provider, and you can do this also as a nurse, is understanding if there's any pain in the flanks, looking to see if you can actually touch the flanks down the sides and cause any discomfort to the patient to elicit some more information about what they're doing with you. And then also pushing on where the bladder goes to see, are they, very full? Have they been producing urine? You want to know stuff like that about your patient. And you also want to just be feeling to see if there's anything weird, anything like mass or tumor-like that you can palpate. This is the diagnostic studies of the urinary system. So we're talking before about putting hands on your patient. And this is where you're getting urinary samples so that you can send them in and look at them. And there's the macro and the micro. You also send in blood to get a chem panel, and we'll talk about that in a second. This is all associated with slow number 1. So in your macro urinalysis, of course, we're looking at things that we can actually see under a microscope. And some of this stuff is just a dip test that they can do to see it. Things like the specific gravity. We want to know, like, what is the density of this sample. The pH, also another, dip. You can figure out pH of it. And urine tends to be pretty acidic, as you can see, from 4.5 to 8. We don't want to see protein in the urine. That means bad stuff if we do see it. So protein coming out of the system needs to be very regulated. It should be very low. The higher it is, the more we know that the kidney is not doing its job of taking out all the amino acids and throwing them back into the system. It means that they're meeting up, they're creating proteins, and those proteins are now coming out of in the urine. So we don't necessarily want that. What white blood cell count? There should always be a little bit, right? I mean, there's a white blood cells everywhere, but we don't like it when it gets higher. It doesn't bode well. It means that there's definitely some kind of infectious process happening. And then, of course, blood is also not great to see. We want to see very small, tiny trace amounts, if any. And when we do start seeing blood, we're starting to get worried that there could potentially be glomerulonephritis, which we'll talk about later, and I have such a hard time saying that word. The leukocyte esterase should be negative, so we don't like seeing that they're fighting anything, that there's any infection process. Glucose or sugar should be low. Ketones should be low, and then the bili should be pretty darn low. Just knowing that if your white blood cell count is going up, you're paying attention to the quality and the smell of the urine, because the higher it goes up, the more likely you're going to see cloudy urine or that pyuria, that pus in the urine. And you just want to keep an eye out for that. The higher it goes up, that means literally the infection has probably gone up from the urethra, maybe to the bladder, now maybe up to the ureters and to the kidneys themselves. So you definitely want to keep an eye on the quality of the urine. The microanalysis is more the very, very small things you cannot see. Casts are indicative of lots of different types of urolithiasis, or urolithiasis. There's a couple different ways to say it. We're going to talk about that a little later. And then urine cultures, we love doing those, especially with our cystitis or UTI patients, because we need to know exactly what's growing and causing all these problems. And then once we know that, we can do a culture and sensitivity where we see which antibiotic is going to actually fight this thing successfully. Instead of pounding somebody with all these antibiotics, we try to be very mindful of which one we're giving them and be mindful of the ones that are not working, so that we can put it in their chart and say, hey, there's methylicin, I cannot say that. MRSA, so they also have MSSA, MRSA. There's a lot of different things that people that get a lot of UTIs can experience, and antibiotic resistance is one of those things, even though I cannot pronounce it. So urine cultures are really important. And remember, you always get a urine before you start your antibiotics, because if you've already started your antibiotics, it's coming out in your urine, it's going to be hard to get that urine culture done and get it accurate. So you definitely want to know that as a nurse, that if you're seeing something off about the urine and you're about to give that antibiotic and you haven't told the doctor yet, you may want to hold for another 10, 15 minutes, have a conversation with the doctor, see if you need to get a UA, and then send that off, and then you can give them their first dose of the antibiotic. It's very important. And something else about the UA is that you don't let it sit on the counter for like 2 or 3 hours before you send it down. You try to send it down as soon as possible. And if you're not going to be able to, then you put it on ice so you can hold the stasis to any growth until it can get to the lab to be processed. All right. So here's the video I was talking about. The first 5 to 6 minutes are perfect. You should watch it. It tells you a lot about the system and why it functions the way it does. So I highly recommend it. It's a great review. When you get that chem panel, one of the things, in addition to the electrolytes that you're going to see, is you're going to get the BUN or BUN and the creatinine. And these are your two levels that you want to understand, because they're going to tell you how are the kidneys processing everything in the body, how are they functioning right now. And you need to know that, because if you're giving your patient medications and their kidneys are injured or not processing things well, it may end up circulating within their body a lot longer and could affect them, and side effects will get bigger. So you want to know these numbers and make sure that you understand if your patient is urinating, what's it look like, do they have a collection device? All these things are important. So discussing the BUN or BUN initially, and also GFR is still used, but we do know there's a racial bias to the GFR. The coefficient that's used to determine that number, I think it ends up delaying treatment for a lot of folks, especially like African American folks. So they might get further injured before we do anything about it, because the GFR has been like tricked out so that it's more specific to the race. So honestly, we try not to use it much anymore, because we have the BUN and the creat, and those are much better at telling us the story that we need to know. Maybe nephrologists will use the GFRs. We're going to use BUN and creat. So the BUN, the book says 8 to 21 is normal. Here our slides are saying 5 to 20. So you're just going to see what your hospital labs say in terms of the normal range. And it tells us how much nitrogenous waste can be kicked out by the kidneys, or urea, the byproduct of protein metabolism. And it also is produced in the liver from ammonia, NH3. And I don't know if you guys know this yet, but usually when you have a patient that has a cirrhotic liver, a lot of times you're watching their ammonia levels because the higher they get, because the liver isn't metabolizing it and getting rid of it, the more altered mental status you can have. And then that's when you end up giving things like lactulose to your patient, is to try and get them to excrete all the ammonia. So ammonia is very important. So that's just a little side note for those of you going back into med surg pretty soon. So urea production is also tied in with urine flow for the excretion of it. And something to know is that your BUN is going to go up with more protein intake. And Americans are big protein eaters. We love our protein. So we definitely have a lot more like elevated BUN. And then also dehydration can abnormally increase the BUN. So something to think about. Also something to think about is that when you are over 90 years old, this normal range tends to go up. So normal for a over 90 is 10 to 31. So just so you know, we might not treat them as aggressively. All right, so we're going to go over each of these and we can talk about it more in person. But would the BUN be elevated or decreased in these conditions? So renal disease, dehydration, a urinary tract obstruction, protein breakdown, you probably already know that one, liver failure, malnutrition, and overhydration. So it's very important to kind of get a sense of anticipating when the BUN would go up when you see comorbidities or reasons why that somebody is in a hospital. So with renal disease, it's not doing its job. So the BUN is going to go up. If it was doing its job, the BUN would be normal, right? But it's retaining a lot of the nitrogenous waste. So it's going to go up. Again, we just spoke of dehydration. Dehydration takes the water out of it. So now all those numbers, when they're in all the water of the system, look normal. But when you take the water away, those numbers increase. So dehydration means the BUN will go up. With a urinary tract obstruction, like BPH that we'll talk about in a couple weeks, you're going to have it go up. And the reason why that is because that obstruction creates a system that isn't able to release all of its stuff. So you're going to have all of it sitting there, and you can see all the protein and nitrogenous waste is just sitting there. It can't get through, like that giant prostate can't get out to be released from the body. And when it can't get out, it backs up all the way to the kidneys and can create something called hydronephrosis, which is where all that waste is just sitting there around the kidney tissue instead of being excreted when you urinate. So you're definitely going to have an increase in BUN with a urinary tract obstruction, whether it's a BPH or a stone, something like that. Protein breakdown, we just talked about that, like with like rhabdomyolysis, these little old folks that fall down and are on the ground for 2 days before they're found. They have all that like protein muscle breakdown. Their BUN is going to be very elevated. Liver failure, it's actually going to go down because the nitrogenous waste isn't even being converted over. So it's actually going to look like it's going down. It's not actually doing anything, which means it's not getting to the blood where you can actually see it. It's staying in the system, and that's the problem. And that's why we give them lactulose, so they can poop out all that excessive nitrogenous waste so it doesn't mess with their brain and create altered mental status. But funny thing is, liver disease, BUN is going to go up. We can talk about that in class. Malnutrition, you're going to see it go down because you're not eating all that protein. So your BUN will go down. And then overhydration, you're diluting the whole system, so it's going to go down. It's not necessarily a down for real. It just means that there's a lot of water in the system. Okay, and we can make sure you understand what those are so that you can ask me questions and get clarification. So with creatinine, or creatinine, yeah, some people say creatine, but that's a completely separate thing. That is for working out and to get more muscle building. This is creatinine. So creatinine is actually our most reliable marker of kidney function. Okay, you should know this one. Circle it, put arrows going to it, whatever. So 0.6 to 1.3 is our normal range. Of course, the book is different. It says 0.5 to 1.2, but it's negligible. And this is the ability of the kidney to excrete creatinine, which is that end product of the protein and muscle metabolism. And so let's look and see, like, when would creatinine levels be increased and decreased? So liver disease, low protein intake, small muscle mass, like someone who's like a failure to thrive, or just a very small person, or renal disease. So liver disease, you're going to see it go down because it's actually not converting it and getting it out. So we're not going to see it in the blood. It's still sitting in the body. So it's going to go down. Low protein intake, it's going to go down. There's nothing to break down to make it go up. So it's going to go down. Small muscle mass, not a lot of protein to process, not a lot of mass that could be potentially breaking down. It's going to go down. And then renal disease, up. We'll talk about why when I see you guys next. All right, so this is a test called a urine creatinine clearance test. You might hear it as creatinine clearance. It's a test where we literally take 24 hours of urine and then submit it so that we can figure out what's going on at the kidney level, at the renal level. So 24-hour urine collection, which means if you were listening earlier and I said if you don't send off a UA right away, you got to put it on ice, it means you're literally spending your whole shift dumping ice all the time into the system. And usually you're going to get one of those big gray buckets. You're going to have like a special container where you're going to pour the urine in all the time. Every time you go and like empty the bag or they urinate into the hat, you're going to pour it into the system, and it has to be in ice. It has to be cooled. So when you see creatinine clearance test, you think ice, ice, baby. Normal, of course, is 70 to 135. It's not a number that as a nurse I really looked at. I just know what my part is in collecting all of this. And that's why I want to make sure you guys knew that too. That's why I put it in red. What is the nurse's role in obtaining an accurate specimen? Ice, ice, baby. All right. Next. Urinary changes associated with aging. I told you about the BUN, or not the BUN. I told you about, the BUN, how it changes with old age, especially over 90, like my mother. They're going to have a decreased amount of renal tissue because you actually start to lose tissue all over the place. And flow function is not as good. The change of their habits, like they might end up having a lot of overactive bladder issues where they're going constantly. It's like their brain is always telling them they have to go, even with just like 50 mils in their bladder. They might also deal with things like retention because of that BPH, or things are not working. The flow is not coming. And then the impaired immune response happens with age because you just don't have the same hormones flowing around. And we're going to talk about menopause and how it affects women and their urinary system as well. But the overall with aging, the kidneys are just less tolerant of any insults, and not the ones you yell at it, but like literally like, imbalances of electrolytes and metabolites and waste products. It's just less tolerant if they're hanging around a little bit more. It breaks down the tissue. So urinary changes that are associated with aging, and we're going to speak specifically about menopausal factors. A lot of women that are in perimenopause, so going to, maybe still getting their period, just so menopause is when you haven't had your period in 12 months. But a lot of times women will go 10, 11 months and then get it. So not necessarily menopausal yet, but they're in perimenopause and they're starting to feel all the differences in their body. And one of them is just constantly having UTIs. It just feels like it. And you may go give a urine sample and they're like, no, we don't see anything. And other times they're like, oh, I guess we see something. But it's just because all of those like vaginal lactobacilli, all the stuff that helps keep the system in check, like the pH and whatnot, all changes. And then you don't have the flow of like lubricating discharges and all the stuff that mucous membranes go through. And so it just creates this situation where overgrowth of organisms can happen very easily. And then once you put them on an intravaginal estrogen, usually things go fine. And by the way, if you have a uterus, you always need to be taking progesterone, but we'll get to that when we need to get to that. All right, so if they're having a lot of UTI and you're starting to see they're coming in to the ED for UTIs, UTI, you may need to talk to their provider about, hey, have you thought about like the menopausal changes? Like maybe some kind of like estradiol cream, ointment, or the pill. You can actually literally put a pill up into the system to help attack these issues so that the woman can be a bit more comfortable. All right, diagnostic studies of the urinary system. You can see that little stricture there where that red arrow is. Call that red arrow sign. It's because somebody already pointed out what's wrong. So you can see that little stricture there. Sometimes diagnostic studies can also be ways to treat a problem. In the case of this slide, which is for slow number 2, by the way. Yeah, slow number 2. This is a cystoscope, and it's essentially put in through the urethra, put into the bladder, where they can go in and see what is going on. And if you look at the stuff at the bottom of these pictures, monitor for urinary retention and bright red blood post-procedure. And you want to give them a lot of fluids. And if they can take them orally, great. So bright red blood, no bueno. Pink, okay, because there's probably some trauma associated with sticking that thing into urethra. But we just want to make sure they're not having any large clots from excessive bleeding. And we definitely want to make sure that they're not having bright red blood. Again, pink, okay, rosy. And as it's getting better, lighter, then that's what we want. So a cytoscopy looks at the wall directly and it's looking for tumors, stones, ulcers, and it's looking through the urethra to see that everything's okay. And you're going to need separate specimen from each kidney to evaluate the renal function because one biopsy from one kidney doesn't tell you what the other one's doing. You need separate biopsies to make sure that you know what your kidneys are doing. It's going to remove calculi. So again, it can treat things as well as help diagnose them. And it can treat those lesions. And usually they're NPO after midnight. And I don't know if you know this, but midnight might be an acronym MN, big whoop, right? So these are really important. And it can be, by the way, the sedation that they use for this can be local or general. So you're just going to want to know if you're taking care of this patient. All right, question. When caring for a patient who has just returned from cytoscopy, it is most important for the nurse to observe for, you already know the answer. I've already talked about it a lot. Actually, I think that means something bad in English. I mean, I need to do this one instead. Okay, so let's talk about an intravenous pyelogram. So this is another diagnostic study that we're looking at. It's going to include dye, so you need to have a working IV. And what happens is that you lay very, very flat and you're using an X-ray, and it's not X-ray the whole time, it's at certain times. And you're trying to see what lights up in this whole system. If you have poor kidney function or renal function, remember that BUN and that creatinine are both elevated, you may not want to have your patient go down for this. Just double check with the provider that this is still indicated, considering that their kidney function isn't looking very good. We're looking for things like stones, And you can also do a KUB. So this one over to the side is like a KUB where you're getting, so you know it's kidney, ureters, bladder. So you're getting a picture to see if you can see what's going on. And in this case, you can tell on the right slide that they're seeing stones in the kidney. So it's helping us to diagnose that. For an RN, you need to make your patient NPO. You need to make sure they don't have any allergies. And I believe there's a drink that they have to drink in addition to the dye so that you can make sure that everything is all lit up. All right, so diagnostic studies of the urinary system. So that means ureters, bladder, urethra. In this picture, they're showing renal studies. They're showing us that. So just remember. All right, the KUB, the kidney, the ureter, bladder. There's no prep involved in this one. It's just a flat plate x-ray, very easy. You may need to do some bowel cleansing. So you might see that go lightly jug in your med room. It's going to be a bummer for that patient. The same one they use for like the colonoscopies and whatnot. So there may be some bowel cleansing involved, and it helps to identify where the calculi are or those stones are. Okay, so let's talk about classification of UTI, which is AKA cystitis. So you might want to write that down because if you see the word cystitis, you should be automatically thinking UTI. And when you see the word UTI, you should automatically be thinking cystitis. Those two things should be interlinked in your brain. So there's upper tract, which is called pyelonephritis. And then there's the lower tract, which is where you're going to have UTI. So cystitis, a little bit more specific to the bladder, urethritis, urethra, but all together, we pretty much just kind of call it cystitis or UTI. So acute pyelonephritis, the further up high infection, can cause some pretty bad inflammation. This is slow number 3, by the way. The inflammation of the renal parenchyma and the collecting system. So that means all the little areas around and then where it sends all the waste products so that it can go to the ureter. I think you can say it both ways. Ureter down to the bladder to be excreted by the body. And it's usually most commonly caused by bacteria, but you can have fungal, protozoa, and viral issues as well. And generally speaking, it probably came up to the kidney, probably started lower down. Maybe they had no symptoms whatsoever. Maybe they did and they ignored them and it just seemed to go away. So urosepsis is a systemic infection from a urological source. Or they may say sepsis secondary to, so with a 2 and then a little circle, secondary to a UTI is another way that you might see it in notes. And you can have multiple UTIs. You could have even BPH complications, so benign prostatic hyperplasia complications. Maybe you even have chronic Foley. You're just always have to have a Foley. So there's a lot of different ways to get a uroseptic infection. And these need to be diagnosed and treated as soon as possible because they can lead to shock. Sepsis is bad news, and that's why you have those sepsis alerts in the hospital, where that if the algorithm starts to notice different things are slowly moving up, like heart rate, temperature, maybe it's cross-referencing, a UA or something, it'll put you on a sepsis alert, and you need to act on that. And this is one of the most common reasons why people are admitted to the hospital from a sniff. Clinical manifestations of these types of like higher up infections and lower down infections is mild fatigue, chills, fever. You also have the nausea, vomiting for some patients. Just the malaise, just not feeling good. Flank pain is very important to know about. And then, as you know, cystitis is a UTI. So we're really talking about pyelonephritis and maybe all the little things that led to the pyelonephritis. The costovertebral tenderness is very important. Again, remember in the beginning of the lecture, we talked about putting hands on patients. You want to know if they're actually getting tender in those flanks because you could be actually noticing now hydronephrosis or a lot of swelling where the water is just holding there. All those waste products are just sitting there, and it could start to actually be physically noticeable on your patient. The question down here is what symptoms may be different in the geriatric patient. Okay, so you might have pretty gross hematuria. And I don't mean icky gross. I mean like there's a lot of blood in the urine. They might have very, like normally they have a little bit of urgency, but now like they can't make it. They're peeing their pants, they're peeing in the bed. Their fever and dysuria might be really fast and quick or very low grade. And you have to be like, oh, this is actually not normal. I think this 100 temp probably needs to be dealt with, even though maybe your Tylenol PRN is for 100.3. You might want to call the doc and say, they've had the same temp for like 2 shifts now. I'm thinking that we may need to look deeper into that. And then, of course, one of the main issues with a UTI or a pyelonephritis with the elderly is the altered mental status. They seem like they almost had a stroke. And that's why when they come to the hospital, one of the first things we do is run a UA just to see if we can see anything. So diagnostic studies would be those urinalyses, the micro and the macro. In the macro, we are definitely looking at that white blood cell count to see like how high is it, and do we think that this infection that we're suspicious of has gone from the lower region to the upper region. So is it turning from like a UTI into a pyelonephritis? And then of course at CBC, we want to see what is the white blood cells in the blood doing, not just in the urine. You might also want to, check and see if cultures are reasonable. And again, if they've already started antibiotics, that culture probably won't be very helpful. So if you have the opportunity to get a urine sample before giving an antibiotic, do it. And just put it on ice and then call the doc. It's not that big of a deal to get a urine sample. All right, and also, by the way, I'm sure you guys remember this from maybe first or second semester when you get the shift to the left, and that really shows an acute infection. So you're going to see that with your numbers, your data. So this is slow number 3. One of the most important things that we need to do for these types of patients is to flush them. So IV fluids are going to be very important. And then once we get those UAs, maybe we can go ahead and start those antibiotics. The antibiotics can be given orally. A lot of times in the hospital, they might actually just start giving them IV. They might start with a broad spectrum until they can get the culture and sensitivity back, and then they can maybe pinpoint which exact antibiotic would be helpful. So you may anticipate getting a second antibiotic thrown into the mix once that information is available to the providers. And then, of course, NSAIDs or antipyretic drugs. We already talked about Tylenol or acetaminophen. You might be giving naproxen or ibuprofen, probably not aspirin. Those are more for our cardiac patients. But keep an eye on those fevers, keep an eye on that discomfort. And then urinary analgesics. I don't know if you guys know about like AZOs, pyridamine or pyridine. Forget how to say it right now. You want to give them those. And the thing to remember with those is that it's usually going to turn the urine bright orange, like stain your white underwear and white pants orange, bright orange. So just make sure that you're aware that if you're giving these urinary analgesics, that is a very common side effect for those. And then other common urinary medications, aminoglycosides, and those are all sulfas. So if you have a patient who has a sulfa or sulfur allergy, you may want to remind the doctor of those allergies so that they don't receive these types of medications like Bactrim. So somebody with a sulfa allergy, the nitrofurantoin is a good one for them. That's a very common one that they start, and then while they're figuring things out. So it's not as helpful, but it's a good one to start to see if it works. If it doesn't work, then we can give them something else. But if it does work, great. Let's do that. And then, here's the pyridium, the analgesic, the urinary analgesic. That's really helpful. You can buy those over the counter as well. And then alternate antibiotics might be Cipro or Azectam. So there's a lot of different options. Your pharmacy is always watching what antibiotics are becoming resistant in the population. So this list will probably change over time. Okay, so we're not with an audience right now, so we're just going to go for it. A nurse identifies the patient with the greatest risk for urinary tract infection as a... All right, so is it the 37-year-old man with a renal colic associated with kidney stones? Remember, the colic is kind of like the spasmy. Or is it the 26-year-old pregnant lady who has a history of urinary tract infections? 69-year-old man who has urinary retention caused by BPH? Or is it the 72-year-old woman hospitalized with a stroke who has a urinary catheter because of urinary incontinence? Beep, 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 ding, 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 whatever you want to say here. That urinary catheter, that's our smoking gun. And any one of these, of course, could have, UTI, but the person who actually literally has a plastic tube going into their bladder where bacteria can travel up, that's going to be your smoking gun for that one. Okay, this is slow number 1 and number 4, and I'm going to keep trying to say this word. Glomerulonephritis. I have a hard time saying it. So this is a post-strep infection. So you see that streptococcal infection? If you had strep throat, amongst other streptococcal infections, this is something that we're always worried about, and not for like 2 days. We're worried for like a couple weeks that a patient might end up getting this. It's an autoimmune response. So the strep creates this immune system frenzy, and it doesn't go away. And it just starts, once the strep is gone, it keeps attacking and looking for it. And so this tissue in the kidneys is definitely one of the attack spots. So post-streptococcal infection, you're always asking like, hey, did you have strep throat or a cold or anything like that a few weeks ago or within the last few weeks? And so you're always just kind of asking those kinds of questions, but it's more provider level, but it's always good to know that stuff. It's very similar to maybe something you guys have seen called Goodpaster's syndrome. And then also remember lupus. Lupus is an autoimmune disease. So it comes in many different ways. The complements, the immune complements, are deposited on the basement membrane of the glomerulus and result in that injury and inflammation. And it can actually be chronic or acute. And the main issue that you're watching for with this problem, because the filtration system isn't going to work very well, is the edema. It's the backup of all the waste products and waters that are not getting filtered and sent out of the body. It's going to start to back up. So you have a lot of problems with edema. And so you're going to probably end up putting them on like a fluid restriction or sodium restriction, not necessarily using diuretics. And we'll talk about why in a minute. So slow number 1 and 4 again. We're looking at a UA and a chem panel to help us understand this patient. We're looking for protein in the urine because, again, protein in the urine means that there's something wrong at the kidney level. We're looking for hematuria, so like a smoky urine. Are there casts? Are there like, early blood cells in there? So not matured ones, but, immature ones. We're looking for that elevated BUN and creat, and we're looking to whether or not this is going to lead to like a renal failure. We don't want that to happen. So we're watching those different labs to make sure that we're not getting worse and worse and worse. We want to see those numbers getting better. And one of the things that you want to make sure is that diuretics, if you remember, especially like furosemide, can be a kidney injurer. So it injures the kidney further. And that's why you have to figure out the risk versus the benefit of giving this medication. And in this case, it may not be the right one. Even though you can see in the treat symptom sections that we would need to aggressively treat hypertension, and a diuretic would be great for that, right? Because you get a lowering of blood pressure and you can get a flow of waste product out of the body. But because the medication will further injure the kidneys, you might want to hold off on using that, even though it's kind of a 2-for-1 in terms of GN or glomerulonephritis. So the provider will take, those steps when it's necessary, but just remember that in the back of your head. That fluid retention is going to probably be treated by fluid restriction and sodium restriction, not necessarily diuretics. So yes, treat UTIs aggressively, treat hypertension aggressively. We need blood flow to the kidneys to help it fix this problem. And so if you get very hypertensive, it might cut off blood flow to those kidneys, at least to the point where we can actually do any good for the kidneys. Monitor the protein in the urine to make sure that we can figure out how poorly are these kidneys functioning. And if that BUN increases, we might need to talk to nutrition about restricting their proteins. Inflammation can be treated by steroids. And then if of course, it's autoimmune. So if it's still progressive, we may need to use some plasmapheresis and consider giving them some IgG to help them fight this. Okay, so how do you prevent this acute post-streptococcal glomerulonephritis, APSGN? Take all the antibiotics, because most likely they had the strep throat. It's not a virus, it's a bacteria. So you can take that antibiotic and get rid of it. Just because you start feeling good doesn't mean you stop your antibiotics. Make sure you're teaching your family that. Kidney stone, TED, 5-minute videos, very good. Okay, let's talk about urinary calculi or urolithiasis. Fancy word, huh? There's also nephrolithiasis, so stones in the kidney or kidney stones, versus bladder stones. There's a high risk of this happening when you have a dehydration, because you're just all these different solutes that, with all the water in the blood, don't necessarily find each other easily. If there's not as much water in the blood, if your blood pressures are low, if you're not drinking enough water, those solutes might end up forming solids. And that's where your crystals and whatnot, your stones, can come from. And then if these are left uncorrected, then you can end up having that, remember that obstruction means that nothing is getting out of the system. You get that hydronephrosis, and then therefore you can end up having some renal failure. So you can see the S on that one picture and the little yellow arrow on the other picture. That's a stone. That's a calculi. That thing is massive. There's no way they can get that through a ureter. No way. So you have to think of other ways to help them tackle this, because this is intense. Gnarly pictures. Okay, so here's some of those really pokey looking ones. These are going to be very uncomfortable to pass. Very uncomfortable to pass. And we're going to talk about oxalate ones. We're going to talk about all the different types. So I guess Justin Bieber had kidney stones at some point. He's had a lot more going on since I think this slide was made. I initially thought it was because it says more common in white men, but I didn't know he had stones. So apparently that was the reason why this person used the picture. People in your family, if they have stones, it's more likely that you'll have stones. And it happens again. If it's happened once, it's going to happen again, most likely, 50%. Stay hydrated. History of gout. Do you remember how when grandpa ate too much shrimp and drank too much brown liquor, and now he's dragging his foot around? I got the gout. So that's also a crystal formation in the extremities. So if you have a family with history of gout, it could potentially mean that you're more likely to have a renal calculi. It can happen after infection, just because of all the different stuff flowing through the blood. Immobility, remember, all that stuff can find each other if you're not moving around and keeping things healthy and happy. And a diet high in calcium, oxalate, or uric acid. So you gotta be careful about those three. So pain shooting down to the groin, that's one of our clinical manifestations. And also flank pain. That spasmodic pain, that's that renal colic. It's where it's trying to do its job, because there are muscles in that ureter, and it's trying to pass things down, and something's not letting it. So it's going to try even more to make it do that, and you have that spasmodic type pain. But let's go back to flank pain. Remember when something is blocking all the waste products from being able to leave, you might actually physically see the flank start to take on some swelling. And that's that hydronephrosis that we're worried about. So you want to keep a close eye on them. Just, run your hand down that area, see how tender and sensitive they are, and then do it again before your shift is up, just to make sure that it didn't intensify during your shift. The labial or testicular referred pain, remember referred pain from the pain lecture talks about how it's moving to a different area than where it originally there's a problem. So that referred pain is one of those things that can happen with these hollow type organs or visceral pain. You kind of read it somewhere else. And then apparently you'll see people doing something called the kidney stone dance. They're moving around a certain way. I don't think I've seen that. And like we talked about, it can easily progress to hydronephrosis. Slow number 5. This is a very important slide. You guys should all know this slide inside and out. Collaborative management. Woo! This guy makes me giggle every time I see it. So different things that you can do. That CT is going to help you see stuff. It's high sensitivity and it can note an obstruction. So it's very helpful. The IVP, I actually forgot what an IVP is. I'll come back to it. The cytoscopy, remember that thing that can go up your urethra into your bladder from the beginning of the lecture? That's that cytoscopy that can use to diagnose and treat different things. It can help with this. It can diagnose and treat a stone. You're going to hydrate your patients. So at least 2 liters a day should be flowing into these people, whether it's IV fluids or drinking. You need to get them drinking so they can urinate, so they can see if we can push this thing out of their system, and also to see if we can stop all of those solutes finding each other. If we can create more solution, it's going to be harder for those crystals to find each other and form. So hydrate your patients. You're going to control their pain as best you can. From the pain discussion, we talked about how ketorolac or Toradol is quite often used for patients with kidney stones. It can be used IM if you don't want to put an IV in them and you want to get them home ASAP from the ED. Or if you have them on the floor, then you might give it IV. You're going to control any infections, because if things are not flowing, then bacteria can take hold and start growing. So we're going to keep an eye on all that. Lithotripsy is where you go in and you try to break it up with shockwaves, which is what's going on with this guy in the picture. I don't think he's falling. I think he's just got to leave his hands up like this. And I'm not sure you have to be naked for this, but I've never done it, so this could very well be very accurate. So it's where shock waves are sent at it to try and bust it up, because maybe it's too big to move through the ureters. And so the nursing consideration to know for the lithotripsy is that you're always going to put ice on anywhere that looks like a hematoma or is bruised. That's what happens with these shock waves. Surgical removal, if necessary. It's just too big to pass. And that's usually after 4 to 6 weeks, or if the stone is maybe greater or equal to 10 millimeters. So it might need to have somebody help you with that. And then dietary referral, we'll talk about why, because you can actually create more of these stones with eating the wrong things. And so it's good to know if your family has them so that you can maybe manage that. So the different types of urinary calculi, 35 to 40% and / most common is the oxalate stones. You're going to monitor those calcium levels. You're going to try and reduce your oxalate intake. And my next slide tells you which foods are high in it. You need to know that stuff. It may be idiopathic hypercalcemia, like we don't know where it's coming from. So you just got to make sure that you're managing that. And then giving potassium citrate to help alkalinize the urine so it's harder for these stones to form is helpful. And then calcium lactate to help reduce the oxalate that's already there. And again, hydrate, hydrate, hydrate. So foods that are high in oxalate, I mean, beans, beer, beets, and berries. That's hilarious and easy to remember. But not bananas. Even though bananas are high in potassium, you don't necessarily need to eat more bananas to get more potassium in the system. That's not what we mean by when we say potassium. So don't worry about that. Foods high in oxalate, you want to know these. Look at that black tea. There are a lot of cultures that drink a lot of black tea. So you're going to be mindful of that. Cultures that eat a lot of tofu. So you're going to go over these and make sure you can remember them. All right, additional urinary calculi. Now you have a calcium phosphate, which happens more like 8 to 10% of the time. And these are usually struvite and oxalate together. And so the key to this one is to keep the urine acidic and then treat the underlying cause. Why do they have so much of these issues in their blood? How can we, rebalance them? And struvite, more common, 10 to 15. I think that's the one that's like super spiky looking from that picture. And most commonly associated with UTIs. So again, keep the urine acidic and treat those infections. And apparently the struvite ones are the most common in women. Luckily, we have the shortest urethra. So it'd be good for those of us that get calculi. It's bad because it usually means that we're having more UTIs or cystitis. But, there are good things and bad things. Uric acid can lead to 5 to 8% of the renal calculi. So we've moved out of the urinary calculi, and now we're in the renal calculi. So uric acid, which is what is associated with gout. So again, history of gout, you might be prone to these types. We're going to alkalinize the urine in that case with the potassium citrate. So we don't want acidic urine, we want alkalinized urine because it keeps the uric acid in solution and not finding each other and forming crystals. Allopurinol is the treatment for that. I'm sure you've seen that before. I have another slide with medications. We'll go a little bit more into depth about that. And then reduce your purines. And those are your livers, eating livers. There's a lot of, my mom used to serve me liver. I loved it when I was little. I wouldn't eat it now, but I loved it when I was little. Meat, herring, mussels, sardines. And then the least common are the cysteine calculi, which is more of a genetic defect. And you just make sure you're drinking potassium citrate, alkalinize that urine. And it's usually treated with penicillin and tiopronin to prevent the formation of the cysteine. All right, so this is a really important slide. It's not in the book. Thiazide diuretics are helpful. If you looked at that video from the beginning, you'll know why. Because it can promote putting the calcium into the urine and getting it out. So that's a good thing. So it's not sitting in solution and hopefully not finding each other, right? Tamsulosin. So circle this one for me. Tamsulosin is really important because it helps relax the smooth muscles of the system so you can pass the stone. And they're still going to scream and yell, but it helps them get it out. The problem with giving them the tamsulosin to help them pass the stone is that it will drop their pressures. So you have to monitor for that change in position blood pressure, orthostatic hypotension. You're going to keep an eye out for that, and you're going to put your bed alarm on your patient, and you're going to tell them, are you feeling any dizziness or lightheadedness when you sit up? If so, please call me. I need to know that stuff. Potassium citrate, we talked about that quite a bit. It binds with the calcium, so it can make the calcium not find other calcium, so it doesn't calcify in the area. And then it makes the urine more alkaline, which can decrease the stone formation. And then, as you saw, allopurinol, which decreases the uric acid production. And you'll see gout sufferers getting allopurinol as well. It does lead to muscle aches, fevers, and chills, though. So you do need to know that about allopurinol. Okay. We're going to go over urinary diversions. So I'm not going to spend as much time on this one because your fellow students are going to be presenting on this, but there's a couple things I want to make sure I talk about, and then we'll be done in just a minute or two. So this is slow 9. For slow number 8, we're asking you guys to look into what bladder cancer is all about. And one of the reasons why urinary diversion is useful is because a lot of our patients with bladder malignancies end up needing diversions. They can't use their urethra to urinate, so I need to be able to urinate out of other areas. There might be some congenital abnormalities that are causing a lot of urinary tract issues, like spina bifida, things like that, where they have something called a neurogenic bladder. They just cannot, their bladder doesn't communicate with their brain. They don't know when to squeeze, when to hold. So you may end up having somebody who has a lot of retention, and this would be helpful for them. And then strictures or trauma to the area. There's different methods by which we do this, but let's look at what they look like so that we're prepared to take care of our patients that actually have these. So you have the ileal segment that gets anastomosed. Remember, that's to bring together and stitch together to the sigmoid colon, and that's an ileal. You have the protruding stoma. So that's the thing that we're going to look at. The thing we can do as nurses is we can keep an eye on that stoma, make sure it's, that rosebud red looks good, especially if it's intestinal, it's going to look like a colostomy. So you're going to have that nice, beautiful red stoma, the intestinal, very well perfused red tissue. You might have cutaneous urostomies that come out of the abdomen. Those are going to be a little different looking. And then you might have like the double nephrostomies that come out from the back. So there's any number of different things that you're going to be seeing. The ileal conduit will have continuous drops of urine because there's no sphincter there. So it's just going to keep coming out. And so you just have to watch. There's no voluntary control over that stoma. The patient will need to wear a permanent external device to capture the urine so it keeps them dry and keeps the skin happy. And the urine from an ileal conduit will have protein in it and mucus because remember it is intestinal mucosa. So it'll have all of that. So don't be scared. The thing to keep an eye on is that stoma itself, okay? When it's intestinal mucosa, it needs to be that nice, red, rosebud looking stoma. Pre-op visits that's the wound care nurse, WOC, wound care nurse. I forget what WOC actually means, but I know that means wound care. Oh, wound ostomy care, I think. Post-op care related to the ileal conduit. They're going to have like some kind of cement on appliance until the edema to the area decreases to the normal size, and then they can start using disposable bags. It's going to drain constantly. There's always going to be output. You're going to want to count the output, make sure you know how much it's putting out because you'll be able to know if there's a problem because it's slowing down or speeding up, and you can't point to anything, any particular reason, like a diuretic or something that created that system. And you're going to evaluate for the bleeding and making sure that it's reasonable because, you will have a little bit. The stoma should be that pretty color. There will be edema, so you want to make sure that it's manageable and that it's going down. And then you're going to do a lot of teaching around this. How do they adjust to having this? How do they go out and enjoy their life? How do they, have sex with some new person? Like, how do you do any of this stuff when you have these things that you have to manage? So that's going to be a lot of teaching, especially from the providers, but as well as the nurses to talk about that. And the main thing, of course, is to always empty the bag when it's, a third full, because if it gets to half, it might weigh too heavy and it might pull it off. They're going to talk about odor control and whatnot with them. Well, that's a nice, pretty rosebud urinary stoma. Ooh, no. No, goodness no. That is blue. You are calling a physician if you see that, especially if they just came out of surgery or something. You're like, it is not being perfused. There is something wrong here. It's not the color that it needs to be. This one, it looks like the mucosa got sucked back in. It's not even out on the skin. It must have gotten pulled back in. So again, you're calling the physician for that one. And last but not least, the patient with bladder cancer undergoes a cystectomy with formation of an ileoconduit. During the patient's first post-operative day, the nurse plans to 1, test the urine output for protein and mucus. We talked about that already. 2, measure and fit the stoma for a permanent appliance. We know better there. 3, teach the patient to self-catheterize the stoma every 4 to 6 hours. Do we need to do that? Or 4, empty the drainage bag every 2 to 3 hours and measure the urinary output. Ding, ding, ding. Okay, I will see you guys in class. Please bring me your questions, things that don't make sense, that you need clarification on. I'm more than happy to address it. Hopefully I didn't confuse everybody or speak incorrectly about something. It happens though. So make sure you talk to me about it so that I can make sure you are clear and ready for your exams. All right, good luck. Thanks.